Hello, it's Dr. Centeno, and thanks for joining me today. Today we're going to talk about the top 10 things I want patients to know right before they get the PICL procedure. So we send out information to patients, and that includes a very long 12, 13 page pre and post PICL instructions. Having said that, patients being patient sometimes don't read it or they just skim over it. We have them sign it again, and initial each area when they get to the office. But on top of that, I also am going to start initiating sort of a top 10 PowerPoint video that they can watch that goes over the top 10 things I want them to really pay attention to if they're just not paying attention. And what we've noticed is that we've got some patients that are very educated and have educated themselves and they know what's going on. We have other patients less so. So this will focus those people in. And I'd like to crowdsource this a little bit today. So what I mean by that is I'm going to go over that top 10 list. You may have other things as a patient you'd want to see on there. And so this is for patient comes in, they get an evaluation and they'll be required to watch this short video just to focus their attention on some important things. So I'd like your help in just telling me, do I have the right 10 things? Would you add or delete some of the things from this list? I'd like the video to be about 10 things long, maybe it could be 15 things, but I want people to pay attention to it and really focus on some very key things they should know when they're sitting in that position in the office, right about to undergo their PICL procedure. And they may not have really read the information we give them. So this really isn't for the patient who's highly educated, done a lot of research, really tried to focus in on everything we sent, has watched all of my videos, etc. This is more for a low information patient, and that low information patient is maybe a little confused as to what this is all about and what they're getting themselves into, etc. So I'd like your help with that. So I'm going to go over that, and then once I go over that, I'll get to questions and answers. But again, we're going to go over that top 10 list of things that I think a low information patient should know if they're sitting there right before the procedure. So let's go over that. You can tell me what you think I got wrong, what you'd add, what you delete. I always like to crowdsource these things a little bit so that you guys can see what's going on. So let me share my screen here and we'll get going. Okay, so this is going to be those top 10 things to know before your PICL procedure. So this is going to be part of a new video that patients will be required to watch when they're in the office. So they'll get their evaluation and then they'll be required to watch this. Goal is not really, again, to educate the high information patient. And we have a lot of people like that. They've watched all the videos, they've read all the stuff. So this is going to be repetitive for them, but to really target that low information patient that maybe didn't read the stuff and try to see what's going and give them some information. And we may have some issues. StreamYard was telling me that they may not have great connections right now to Facebook. So just to let you know, you may or may not be experiencing some intermittent issues or problems on your side if you're on Facebook. I think that's more of a StreamYard issue. So the goal of this presentation is to focus your attention on the 10 things to keep in mind before your procedure. Remember, this is a low information patient who's sitting in my office. Maybe they didn't really read all the pre-information. They're not 100% sure about what's going to happen. They have some idea. So this is the top 10 things for them to know. And I'd like to get your feedback on some of these things to try to see if I've got the right top 10 things. Would you add some? Would you subtract some? What would you do? So the first thing is just to let them know that everything you need to know is in the post-PICL instructions. It's a very lengthy document, 13, 14 pages now. They can go through and they're supposed to initial each one of these things. It talks about before your procedure, during your procedure, and after your procedure. So the first thing is, hey, there's this document here. You have this document. It's been sent to you via email. We're going to give you another copy today. We'll probably even email you another copy after the procedure, but this is going to be where you want to go to find things out. The second thing I want them to know is right after the procedures, most patients are sore with decreased neck range of motion. And, we get kind of a little bit of everything, right? We've got everything from not very sore to slightly sore to sore with increased symptoms to very sore right after the procedure with significantly increased symptoms. And then as far as the flare-up duration here, that most people are in this 3 to 10 day range. Some people are on this side of the bell curve where they don't really have much of a flare-up at all. Other people are on this side where they're flaring up for longer. Number 3, you can text Dr. Centeno. There's my mobile number. If you have a problem, you should do this if you think you could need to go to the emergency room to get checked out. And that a big issue to be concerned about would be if you had fevers, chills, sweats. Those are things in general contact the doctor about, or if you're having other issues. If you don't get a response to the text, you can call that number. And then everything else should be handled via email. And I have this one in here because sometimes I'll get, random texts from people asking just random questions that are already covered in the PICL instructions. And obviously, if you're contacting your doctor after hours, you should really only do it if there's something really substantial going on. Number 4, if you need additional pain medications, sort out early in the day. I've had a couple of patients do this where I get this emergency call at like 7, 8 o'clock at night. Hey, I need some more pain medications. You didn't know that at 2 p.m. kind of thing. So this is important because obviously it's much easier to do this during normal business hours. If we need to e-scribe something, that ability comes out of the office, etc. So this is an important thing to think about. We do give about 1 in 5 patients additional narcotic medications, but we balance that against the fact that if you give patients free access to narcotic type medications after a procedure like this, there is an addiction rate. So we're constantly trying to manage that so nobody gets addicted to narcotics as a result of any procedure, whether it's this one or another one. Anesthesia, oral narcotics, and sometimes the PICL procedure itself can cause nausea. Some tips: cannabis users will require higher doses of anesthesia to stay asleep, and research shows they have a much rougher recovery. That's pretty well established now in the peer-reviewed literature. Same thing goes for patients on pain medications or low-dose naltrexone. And then just give the patient some advice if they come back again, consider getting off these things 1 to 3 months before your procedure. That's in the instructions. They've already gotten this, but this is for someone who really didn't read the instructions. Stop taking the narcotic script and switch to Tylenol. That's a big one. Percocet and other narcotics can make people nauseated. So sometimes a simple solution is if you don't really need the narcotic, stop taking it, go to Tylenol. That'll help calm your stomach down. And then again, reminding them about 1 in 5 people come in the next day after PICL for IV hydration and anti-nausea meds. And again, most people don't need it, but about 20% of the time people come in and they do that, and that's fine with us. You need a caretaker for the first night, preferably a family member. If you don't have a family member, you need a nurse. You just need to have someone there who can be your advocate and to help you with things like when you get up to go to the bathroom, because after anesthesia, it's not uncommon to fall. We've seen a few people through the years who have taken a nosedive just because they're a little disoriented from the anesthesia, from the procedure, whatever that is. We're at 5,400 feet here in Denver, and it's a very dry climate, so you got to hydrate frequently when you're here. Also, again, that gets back to that dehydration thing, which can happen very easily here, meaning that it's very common for a patient who can't keep anything down or they're nauseated, they really don't feel like drinking or eating after the procedure, to get very dehydrated. So again, about 1 in 5 of those patients come in to get IV hydration after the procedure. And then prior to and after the procedure, we're going to start with an antiseptic gargle. We'll spray an anesthetic at the back of your throat. Then you'll go to the procedure room and we'll sedate you a bit. We'll then work with you to put that 3D printed mouthpiece in. You will then get fully put to sleep. When you wake up, you'll be headed to or in recovery, and then you'll be in recovery for about 60 to 90 minutes before you get discharged. So just letting people know what's about to happen. And then anesthesia requirements, obviously nothing to drink for 2 hours before the procedure, can't eat anything for 6 hours prior to the procedure. And then finally, this is a really common question I get post PICL, and that is, when can I start exercises? And that's really up to the individual doctor to determine. So we always want patients reaching out about this, because for some patients, it can start right away, and for others, they're really not going to tolerate this. And then again, finally, just reminding them that there's this huge document out there where all of this information is in there, and pointing them to the fact that they have this document. It was sent before the procedure. We give them another copy when they're in the office, and we usually send another copy electronically after the procedure. So that's it. And those are sort of the things I want patients to know. So let's go here and start answering some questions. Bo, what are your thoughts on chiropractors using the torque release technique for someone who has an atlas subluxation and unsure if they have CCI? I don't know the torque release technique. Let's see what that is, what it looks like. Torque release technique. I mean, it looks like a low force type procedure, so I'd probably be fine with that. I can't say, at least on the limited amount I know right now, but it looks like a low force procedure. So that would probably be fine. AT, great communication. Dr. C was wondering what Rolfing may accomplish that separates it from other MFR techniques. You know, Rolfing is sort of like myofascial release on steroids. It tends to be deeper work, and it tends to have a postural endpoint. So what I mean by that is that Rolfers take pride in taking, AP and lateral pictures of the patient, trying to release everything up here, for example, to allow the fascia to allow the patient to have a normal posture. And that's one of the reasons I like it. Now, the question would be, can a lot of our PICL patients tolerate it? And the answer maybe not. So if you can tolerate it, though, I think it's a great way to go to get that. Hope you're well. I wanted to ask you, you said CCI can also be caused by an unstable jaw. How so? Oh, more the opposite. So more that CCI patients use the anterior strap musculature to try to stabilize the head on the neck. So more the other way, and then that leads to TMJ. AT, which hand on exam in regards to thoracic stiffness, what indicates an issue is more likely from a bulge herniation. Yeah, so AT there, we're trying to find a correlation between what's on the thoracic MRI and what's on the neurologic exam. So that would be decreased sensation in one of those thoracic dermatomes there, associated with pain or spasm at that site. But it's usually decreased sensation that matches a level that we can see on the MRI. And then that's going to lead us more towards treating that nerve at that level. Duck P, in your experience, what percentage of your SI joint instability patients have to get their pelvic ligaments treated as well? Pelvic ligaments. So you'd have to redefine that. The ligaments that we would normally treat would be the short dorsal SI joint ligament, the long dorsal SI joint ligament, sometimes the sacrotuberous and spinous ligaments at the bottom of the sacrum. I guess you could call those pelvic floor ligaments because they tend to support that back side of the pelvic floor. And then sometimes the symphysis pubis. So let me know if you're talking about something else. Duck P, I believe you have talked about EDS males needing 4 to 6 prolar treatments to stabilize the SI joint ligaments. The same holds true for the other areas such as hips, ankles, etc. Not really EDS males, but the average male, if we were treating the SI joint, might need, let's say, 3 to 4 SI joint ligament treatments. The average female would be more 6 to 8 prolo treatments in the ligament. Then that goes down in half for PRP and half again, number of times for bone marrow. As far as other areas, no. Other areas tend to stabilize more quickly, in my experience, than the SI joint. John Gardner, can C1 instability cause tightness in the SCM from below the ear to the clavicle? Yes, we see that a lot. The sternocleidomastoids are the primary movers of rotation of C1 on C2. So we do see a lot of C1, C2 instability that leads to SCM tightness because that joint is where 50 to 60% of the rotation happens. And this muscle is the primary mover in rotation. So the two are very much linked. John, I read your study on C-arm guided prolo to the supraspinous ligaments to use dextrose nowadays, and these ligaments to use PRP. You know, John, usually what we'll use is a platelet growth factor enhanced PRP. So basically platelet growth factor enhanced prolo. So we'll take a 12.5% dextrose solution and spike it with platelet lysate. So a little bit of both, if you will, but that's generally what we use these days. Bo, do you recommend a NUCA or AO for CCI patients only, or does that also apply to all that have atlas subluxations as well? No, pretty much anybody who's got a problem in the upper cervical spine, I think NUCA and AO are a great solution there. John, have you treated EDS patients that are able to dislocate joints at will? For example, popping hip out of socket manually. Would that be too severe to treat? No, definitely. I mean, I've treated EDS patients that are severe enough to just, when they move their hand, dislocate their finger joints. Those patients generally tend to wear the joint rings in order to keep things stable. So no, we've certainly treated in that range before. Bo, would adrenal gland therapy be helpful for a friend who has an atlas subluxation unsure if they have CCI? How about dry needling? Not sure what the connection is there, so maybe give me more info. Light Hope, is it typical to inject left upper alar transverse, left lower alar transverse, and right lower alar transverse only? Not typical. Normally for the upper alar, it would be just the alar and then more superficial ligaments on the way out. Things like the AAOM, the SAAOL. For the below, quote, lower alar, that's going to be the accessory, sometimes the lower portion of the alar transverse ligament, and then the ALL as the needle comes out. Normally, we do that symmetrically. Now, there are times when, let's say, I'll give you a great example, heavy-set patient who uses a lot of cannabis. Had a hard time keeping that person asleep, really bad airway due to the extra weight. And maybe one of those spots had to be abandoned due to safety reasons. That's possible. But normally it's symmetrically done. So we don't have any potential problems like that. Mohan, hey doc, do you think atrophied multifidus of the neck can cause small amounts of anterolisthesis or retrolisthesis on a flexion extension X-ray or DMX? No. So the ligaments provide stability at end range. So for something like that, translation, those ligaments are going to get a hard stop on both sides in anterolisthesis and in retrolisthesis. meaning forward and backwards. So no, that's a ligament issue. Now, there may also be a multifidus atrophy issue that's not making that problem any better, but that's a ligament issue. Karen, I've heard anecdotally that people with CCI due to alar ligament issues very often have ponticulus arcuate foramen is something you see too. Not really any more in this patient population than any other patient population, meaning we look at the upper cervical spine all day, every day in CCI and non-CCI patients. So I don't really see that association at all, and I don't know of any research that supports that conclusion at this point. Mohan, can atrophied muscle cause the sensation that a mildly lax ligament is more lax than it actually is? Yeah, probably, because I think you're going to see more total instability without that muscle providing active instability to the level. Diana, hey, Dr. Centeno, after my PICL had pain for one day and I'm okay now, maybe with some honeymoon. Does it mean I'm not a sensitive egg like we thought? Sure, that's good to hear. That allows us then to really open up the gate and start to treat more spots. So that's fantastic to hear, Diana. And just obviously keep me abreast as to how you're doing and how the total recovery goes. But that tends to mean that we can open up that funnel a little bit and go a bit faster. Regenetics been advanced by Christy Mater. Can you do a live talk on mast cell activation syndrome and any changes you make for PICL or any medications you suggest for managing? Is cromolyn okay take prior to a PICL or post-procedure? Sure, Christy, we can certainly, I think I did one a while back, so you may just want to search in YouTube and see what's there. But I can certainly say that we see a lot of patients that have mast cell activation, probably represents maybe 1 in 4 of our total patient population. If someone's really sensitive, we can usually give them an antihistamine during the procedure, and cromolyn would be fine to use as well. But certainly happy to do another one of those Facebook Lives at some point here. Diana, should email you in a month about my rehab. I can't move my neck, but do use neuro rehab with the other team for vestibular system, eye movements, or is eye tracking okay in a few weeks? Why don't you just email me in about a month so I can get a sense of where you are and I can make specific recommendations based on how things are going at that time. Elving, hello, is it possible to get the occipital nerves pinched without having instability in any discs, such as they stuck together, rolled into the muscles? That means nerve in turn pinches the blood vessels. Thanks. Sure, yeah. I mean, occipital neuralgia, which would be irritation of those occipital nerves, can happen for lots of reasons. Changes in posture, irritation of the joints in the upper neck causing changes in motion. Some of the muscles just being overloaded on one side, for example, due to things like side bending and scoliosis. So you don't have to have instability to have occipital neuralgia. How does PICL get the alignment back in the instability, or does it just make it stronger to hold when you go to the chiropractor? Yeah, John, if you think about the function of the ligaments, the function of the ligaments are to hold things together at the end range. The function of the muscles is to hold things together at the mid range. So we always tell patients that if you respond well to AO chiropractic, we're going to want you to go back, or NUCA. But that's something good to try before the procedure to see how you respond, in which case we're going to want them to keep it in place as it heals. But the good news is that the shortest point of any ligament will be in neutral, unless there's something from pushing from the bottom up, which would be something like scoliosis leading to side bending and rotation. Roger, I had 3 PICLs in 20 to 21, back in the good old days. But my neck pain and C1 symptoms have come back. C1 overhang has come back. How common are relapses, and how would I go about getting another set of PICL? I wonder if the same thing would happen again, and money is tight on government disability income from Canada. How much has the PICL improved since 2021? Yeah, Roger, quite a bit. I've done quite a few changes. So the changes I've initiated since then would be that we now use biplanar fluoroscopy. So I think sometime in, I'm going to say May of 22, somewhere around there, we added one C-arm going this way and one C-arm going that way, which greatly improved accuracy of targeting. In addition to that, in the last probably 3 months, I dramatically improved the ability to target the alar ligament itself. Before that, we could reliably get the upper sling portion of the alar ligament, but sometimes struggled with getting the mid portion of the alar ligament. And there's a very specific technique I've developed, which is counterintuitive, but works well, in order to target that mid portion of the alar ligament. So it's improved quite a bit since then. Now, if things like that have come back, then the question would be, is there something pushing it out or forcing it out? So some of the things to think about would be kyphosis, head forward posture, or scoliosis, side bending. Both of those will continuously apply pressure to loosen those ligaments. So those are some of the things to think about. Lanaya, for patients with imbalance issues related to CCI, is it possible these symptoms could improve post-PICL? Oh yeah, Lanaya, I would say that about 50% of our CCI patients have balance issues, and that's one of the index symptoms we're looking to improve with the procedure. Regenetics been advanced by Harry Winston. Is there a time frame within which you need to be treated from when the CCI began? No. Having said that, I think, as I've talked about here a couple of different times, if we see patients that are in that first year of injury, those tend to be a single procedure and done kind of patients. So we can rapidly get those people better. Compare that to someone who's had this for 10 years, and the big open question is going to be how much of that neurologic damage that's occurred over that 10 years is malleable and that we can help. So anyone outside of that 12 to 18 month time frame is going to be unlikely to be a one and done, and it's probably going to require many treatments. And there's definitely people who have had this for years who have more neurologic damage that's permanent than others. So that's something we always have to talk to the patient about and take a look at. Levon, hi Dr. C, is it possible to have cervical kyphosis due to multifidus atrophy fatty infiltration? If so, would then curve correction do any good? No, I don't think that's probably the cause of that atrophy. It may be a consequence of the atrophy, or it may just be an innocent bystander that doesn't help, but it's probably not causal. Caleb, what is the healing capacity of the MPFL compared to other ligaments in the body? Since it's outside the knee, does it also respond great to simple prolotherapy like MCL? Yeah, in my experience, MPFL responds pretty well. So just so that everyone understands, that's the medial ligament that helps the patella stay in its groove. Regenetics been advanced by DB. Are there any more basic neck procedures we should get before we schedule a PICL procedure? I mean, that's really dependent on what's wrong with you. So I don't know how to answer that question offhand. I can say that, as I've said before, when it comes to upper cervical injections, we don't recommend any other sites outside of Colorado. So if we're talking about upper cervical procedures, we recommend that you get those here. There are times when we might tell the patient to try a lower cervical procedure, in which case, then that's something you'd want to get done elsewhere. Rhonda, how important is proper alignment of the atlas axis prior to and after the PICL? Yeah, Rhonda, as I was saying before, if you're seeing an AO or nuclear chiropractor, then we're going to want you to continue that. If you're not or really haven't had good experience with it, then we won't have you continue with that. Hi, Dr. Centeno, would a PRP cervical epidural be too risky when there's a high-level disc hernia with severe stenosis and cord compression? Well, a lot of it would depend on how you're getting into the epidural space. If it's in the lower cervical spine, C4-5, C5-6, C6-7, then you can get in through what we call a facet joint overfill. So that means that in most patients who are kind of middle-aged and older, the facet joints will communicate with the epidural space. So there's no reason to go near the stenosis area. And that's probably how we would approach that, because if you try coming in from the back and are laminar, you risk tweaking the cord. You could try to come in from the side, that's transforaminal, depending on how much room is in there. But ultimately, going in through the facet joint and allowing it to fill the epidural space through what we call a facet overfill is the least invasive way to do it that risks the least structures in that clinical scenario. Lanaya, my CCI symptoms worsen greatly during times of stress. Do you have any thoughts on why this happens? Or have you seen a link between stress and increased symptoms? Yeah, usually I think what happens in a lot of CCI patients is that the nerves are always on edge anyway. They're getting irritated all day, every day. And so when some people get stressed, they tend to tighten all this up here, and then that puts more pressure on those occipital nerves, and then they trigger off. I can do this right now. I don't have occipital neuralgia. It doesn't really do anything to my nerves. But if my nerves were on the edge all day of triggering because they were getting constantly pissed off by the instability, then that would cause a pretty quick headache, for example. Regenix, made advanced by Harry Winston. Is there a regimen of supplements that will help us get ready for a PICL procedure within the next year? Sure, those are those stem cell support formula supplements that we have on the Regenix website. You can also contact the clinic about getting those. Simo134, I'm unable to decide if I should just do endoscopic laser surgery to compress the 5-6 disc hernia and stenosis. I don't know. I'd have to take a look at the images. I'd have to interview you clinically so I get a better sense of whether or not that's really needed, or whether or not there's a good chance that things like platelet lysate injections would help. Same person, Simo134, are there risks of PRP cervical epidural, or maybe is a risk of a PRP cervical epidural a hematoma? I haven't really seen a hematoma after an epidural that I've done, especially if we're coming in on that facet overfill. So I would say not if it's done properly. I mean, there may be a little tiny risk, like 1 in 10,000 or something, but similar to dying in a car crash this year risks. Light Hope, 1, if our first PICL procedure was done with a previous provider, and we would really like to have our subsequent procedure done with yourself, and we book a consultation. Yeah, that's usually possible. So just contact Sherry, who's my scheduler, or Ryder, who's my assistant, and let them know what's going on. Amelia, when searching for specific doctors on the Regenix website, it displays the provider is not authorized by Regenix treats C0, C1, or I'm confused because when I reached out to some of the doctors, they mentioned they treat C1, C2. Yeah, Amelia, there's two kind of different things going on. There's what I would recommend, and that's what you see on the Regenix website. So as I think I've said lots and lots of different times with these areas, C0, C1, C1, C2, what I would call high upper cervical facet joints. These are not areas that doctors inject frequently. And doctors are no different than anyone else, right? If they do a procedure frequently, their skill level goes up. If they don't do a procedure frequently, their skill level goes down. And because the vertebral artery is in this area, and injecting into the vertebral artery can be a bad day for everyone, or getting confused by this extremely complex anatomy that's different from patient to patient. You can get confused and put a needle in the spinal cord, for example. So I don't recommend that patients go outside of Colorado, which is what you're seeing on that Regenix website. I'm the medical director for Regenix. Having said that, that doesn't preclude any doctor from claiming I can do this. I think the questions you'd want to ask whatever doctor you're talking to are the following. Number one, for this level, C1, C2, it sounds like, how many of those does this doctor do in a year? And to be competent in any procedure, you would want to do at least 10 a month of something, 100 times a year, let's say. So if it's in the 100 times a year range for C1, C2, I'll let you be the judge of that, but at least we're getting into competency levels that are reasonable, meaning the doctor is doing it enough where they're very familiar with that. And if they've been practicing for 10 years, they've done 1,000. So very experienced provider. Regrettably, that's not usually the case. Normally they do it at max a couple times a year. So if they've been practicing for 10 years, they've only done it 20 or 30 times, which is not enough to develop competency. So that's the difference of what you see there. Regenix doesn't control what doctors can do, but there's what we recommend, and we don't recommend anyone go outside of Colorado for those procedures. Bo, with an atlas subluxation, with adrenal therapy, yeah, I think I've already asked that. I don't know how adrenal therapy is factoring into any of that, Bo. Ryan, is head feeling like it's vibrating, overactive nerve feeling in head a symptom of CCI? Yeah, it certainly could be. There are many other things that could cause that, but it certainly could be a symptom of CCI. Daniel, how is the outcome for CCI patients where 1C instability is the most unstable place? Good. I think treating 1C, again, make sure that whatever provider you use to treat this instability gives you an accurate diagnosis like 1C. So what Daniel's talking about is a sliding type situation where we have the head sliding on C1. And usually you'll see that in a high translational BAI. You'll also usually see a flattening of the occipital condyle. But you need to get that diagnosis because that then tells me that I've got to treat specific ligaments in the front of that 0-1 joint, specific ligaments in the back of that 0-1 joint. Also need to treat the AO ligaments on the side, the posterior AO ligaments, as well as the anterior AO ligaments. So that 1C leads to a completely different treatment plan than a 2B, where we're focused heavily on those alars. So just realize that, Daniel brings up a good point. By starting with a specific diagnosis, he's ahead of the game, right? We have some idea of what it is we're treating and why. Marcia, hi, Dr. Centeno. I've started to stand upright with optimal posture most of the day for the past month. Is that good enough to correct kyphosis, avoiding sitting as much as possible? Certainly very helpful start. So that's great. I think, some of the things you might want to do is just have some people take a picture of you so you can kind of track it over time, meaning from the side. But that's all very helpful. If you can tolerate it, you may want to start strengthening the upper back muscles as well, so you can tolerate that for longer periods. You may want to start looking at curve correction, those sorts of things. Daniel, how long will a disc herniation improve, heal on its own? My L5S1 8mm disc herniation has improved a lot over the last 3.5 years. Yeah, so in general, on the order of 1 to 3 years is sort of what we tend to see with disc herniations. The body tends to clean them up. Robert, do you ever require a CT angio, patient's fear, hitting the vertebral artery or collateral? Can you talk a bit and alleviate what if fears? We don't require a CT angiogram just because it's the equivalent of the 80 chest x-rays and it doesn't really change the treatment plan. So that's 80 chest x-rays. So yeah, we don't do it for that reason. As far as hitting the vertebral artery, I think we've talked about that a lot, meaning that's why we use digital subtraction angiography. For an experienced person, it's possible to hit the vertebral artery. Hitting it and injecting contrast is not a problem. That's done all day, every day in things like a CT angiogram. The problem would be injecting medication into it. So PRP that might have a small little clot in it, or bone marrow concentrate that might have a small little clot in it, or God forbid, an anesthetic like Marcaine or a depot preparation corticosteroid. That's really the issue. And that's why you use digital subtraction angiography to make sure that that does not happen. And that's why anyone that does a 0-1 or a 1-2 without digital subtraction angiography as a package on their fluoroscopy machine, which is not commonly on that machine, you have to get it special as a cardio package, is really asking for potential trouble. CMO 134, so coming from the front of the neck is better for cervical epidural at C5, 6, 7. So CMO, I think what I was recommending here, if it's the same patient, I think it is going through the facet. So that comes from the back into the facet joint, let's say it's C5, 6. Then you test that with contrast, and it will overfill from there to the epidural space. So you're nowhere near the neural structures. You're in the facet joint. I think the type of epidural you're talking about is a transforaminal, where you're coming from the side, which could also be helpful, but is higher risk than a facet overfill epidural. So in the case you described, the safest route is a posterior approach to get into the facet joint and then overfill the facet, and it will flow naturally into the epidural space. Are there plans for a Centeno trained upper cervical clinic for Sydney, Australia in the future? No, there is not. No plans at any time in the near future. Ryan, after a PICL, is there generally certain symptoms that take longer to get better, more likely to notice improvement all of a sudden? It's after a couple of months, or notice something sooner and more progressive? Not really. I would say the most common things we tend to see are honeymoon period that happens probably in half of our patients. So that's within that first couple of weeks. And then things kind of go back to normal, and then they get better over that usually 3 to 4 month time frame. I don't think we see any specific symptoms that get better quicker than others in a PICL. Russian, why do some people have painful disc bulge and other people have no pain with the disc bulge? Yeah, it's a great question, because this is humans are a neuro-bio-chemo mechanical model. And so one of the great disservices done to medicine has been modern spine surgery, where they look at this simply as a mechanical model, right? There's a disc bulge there, it's pressing on the nerve, hence it needs to come out. Bullshit. We've got all sorts of data that shows that that's a bullshit conclusion, meaning that it doesn't make sense. Lots of people with disc bulges pressing on nerves have no symptoms at all. So why is that? That's where the chemo, the chemical part, meaning the local inflammatory environment, neuro, how healthy is that nerve, come into play. So there's other pieces of the picture. So a great example is a low back herniated disc study, right? In that low back herniated disc study, if someone didn't have high systemic inflammation, they had no problem recovering from a herniated disc quickly within weeks. If they did have high systemic inflammation, then they couldn't recover. It took them 6 months or more. Same herniated disc, same pressure on the nerve. The chemo part is different there. Yeah. Hey, Daniel, I did see it. I will get to it this weekend. So I will go ahead and take a look at that and just respond personally to you there. Russian, what blood markers are you checking for when optimized for a patient as a PRP treatment? No particular blood markers. We would want to know if you have low platelet count, because then we'll have to adjust the platelet concentration up. We also check for hematocrit right before all of our procedures, just to see how much blood is in the tank, so to speak, so we don't get in a situation that someone has anemia and we take too much blood. Russian, why do docs use PRP when the growth factors are readily available with platelet lysate? Yeah, Russian, the difference between the two, I often describe it as PRP is like a time release pill, right? We've all seen, probably you've seen pills that are immediate release. That's the older version of the pill. So maybe you had to take 3 or 4 of those a day. And then at some point, the drug company comes out with a sustained release version. Maybe you only take 1 or 2 of those in a day. So platelet lysate is like the immediate release version. All the growth factors are there that can be used immediately. PRP is like the time release pill version where the growth factors are released over time. And there are reasons for wanting both of those, or one or the other. So that's the big difference. Daniel, does Mark Riley specialize in CCI or more of a general physical therapist? Mark certainly has probably seen more CCI patients than 98% of the PTs out there. I don't know that he's specifically a CCI therapist, but because of his job and where he works, he sees a lot. Russian, what do you mean if platelet lysate worked really well for my MSK pain for a short period of time, the overall PRP treatment failed? What does it mean? Russian, I need a little bit more information about specifically what we're talking about there. AT, in regards to my earlier question of hands-on exam for the thoracic spine, is loss of sensation the main component for disc bulge herniation? My issue is throbbing, tightness, and pulling, no loss of sensation. No, I mean, you can have tightness as well, not loss of sensation. So all of that, I'll give you a great example. So when I had my C5-6 disc bulge 7 years ago, something like that, I did notice for a few months before I had some decreased sensation in my hand. I didn't really associate it with much. It was only during certain things, maybe playing football with the kids. And then when this really got bad, it was actually upper back pain that I had more than anything. So much so I was pretty convinced it wasn't my neck. So believe me, you can have referred pain, tightness, pressure, all of those things without really a lot of numbness. Meaning at no time did I wake up and my hand was completely numb, nothing like that. Kimmy, is there a reason muscles and posterior ligaments aside from supraspinous and interspinous are not injected during PICL1? I thought maybe it was just me, but seems to be pretty common among our group of people. No, Kimmy, it has to do with central sensitization. So I'll give you an example here. I now do probably on average about 8 PICLs a week. So that's, let's say, 30 a month on average. Let's give you some rough numbers. Out of those 30 patients this last month, I would say that we probably had 5 of those 30 patients where we only did anterior, well, I'm not even sure we had that. I probably had 1 patient where we only did anterior, 4 patients where we did anterior posterior ligaments only, and then the rest got the full PICL treatment, which would be anterior posterior ligaments, posterior facet joints that are involved, nerves that are involved, other areas of the body that may be involved. So if we chose to do that, it's because we were concerned that you were centrally sensitized and couldn't withstand more than that, meaning in centrally sensitized patients, we're taking the less is more approach. So I think that's really what we're talking about here. Daniel Iverson, can IGF-1 help ligament healing? It's growth hormone for cells, I think. Clinically, your guess is as good as mine. I don't think anyone has a clue clinically whether giving someone IGF-1 or giving someone HGH in that case, or Somatuline, which would increase IGF-1, helps speed ligament healing. I don't think we have any clinical data on that. I call this Facebook medicine, meaning that these things are really popular on Facebook, but when it comes to clinically, do we really know that these things work? We have not a clue. So I have no idea. AT, thanks for the time, Doc. Have a safe, fun trip. Thank you. And just to let everyone know, I won't be here next week and for the next 6 weeks, but I do have 5 pre-prepared Facebook lives that are going out. I won't be doing them, but they're pre-recorded. So you guys can watch those, same bat time, same bat channel, comment amongst yourselves, etc. And then I'll be back and doing all this stuff again. Simon 134, does the PRP help the disc hernia absorb blood fluid to reduce in size? Yeah, I can't say that I can prove that one, but I certainly have observed it a number of times. So if you had to ask me for my best guess, I would say my best educated guess is yes. It probably increases macrophage activity, allowing for quicker resolution of a herniated disc. But again, you know, there's that old adage in science. What do we think? What do we know? And what can we prove? So the think part is I think that should help. That's kind of what we were talking about IGF-1. Kind of makes sense. Could help, maybe. Then there's the no part, which is I've done this 100 times clinically and I've seen this happen. And then there's the what can I prove part, which is actually doing some sort of clinical trial to prove it. Russian, I plate lysate injected in my lumbar caudal epidural space and helped my pain by 90%, but the pain came back after a week. Doctor, it was before I PRP injected into the disc. Yeah, Russian. So usually injecting PRP into the disc only helps if you have discogenic pain or pain coming from the disc. So it's a very specific thing. It's like playing a game of darts and you don't get any points unless you hit the exact middle of the little red thing in the middle of the dartboard, the bullseye. So if you have discogenic pain and we inject PRP into your disc, it'll work pretty well usually. If you don't have discogenic pain, but you just have pissed off nerves, which is what you're describing, putting PRP into the disc isn't going to do anything. It's just adding risk without adding benefit. So if you had a caudal epidural that caused 90% relief and a PRP disc injection did nothing, we know you probably don't have discogenic pain, but you probably have pissed off nerves, sacral nerves usually, lumbosacral for a caudal. So you may need some more specific application of platelet lysate. You may need higher dose platelet lysate, meaning rather than caudal, you may need that transforaminal under X-ray guidance at L5 and S1 to more specifically target the area and get more into that spot. You may need to treat other structures as well to treat ligamentous instability, muscular instability, etc. But regrettably, injecting the disc, like I said, is trying to hit that little red dot, the bullseye in the middle of the dartboard. If you hit it, everyone's happy. If you don't, you get no points. Same thing with injecting a disc. Russian, overall, I got 20% improvement in the treatment. Why would the PRP treatment fail if the platelet lysate helped a lot? I think I explained that already. Okay, guys, any more questions? I've got 6 more minutes here today because I do have a follow-on meeting. Any more questions out there over the next couple of minutes? I will be going on my sailing sabbatical here for 6 weeks. So I will be answering emails during that time, doing telemedicines during that time. So I'm not just sitting around. But I won't be doing Facebook Lives. So obviously, if you're a patient, you need to get in touch with me. I check my emails every day. I'll be on European time checking those emails. Obviously, I've got those 5 pre-recorded things that'll come out. Okay, guys, looks like there's no more questions. So I want you all to have a great weekend. Have a great 6 weeks for your late fall, early summer timeframe here. And then I'll be back doing this. I've got 5 of these pre-recorded on some super interesting things regarding imaging metrics, things like looking at translational BAI, C1, C2 rotational instability, where I put a lot of time and research into those so we can go over what those metrics are that are normal, abnormal, etc., and other topics as well. Things like rehab plans for CCI, what are the goals of rehab for CCI? All of that's going to come out here in the next 5 weeks. So If you're on YouTube, like, subscribe, all of that crazy stuff. In the meantime, those will come out. So I will see you all in 6 weeks, and you guys have a great weekend. Thank you.